This is your walk and die patients, remember? These are the people who've had an accident, a car crash or something, some trauma, bump in the head, headache, whatever, but no big deal. You think, but in fact, of course, they've cut the middle nasal arch with a bone fragment on the skull, and then you've got this high pressure arterial bleeding, building up pressure between the dura mater and the skull itself. And that's what we call epidural hematoma. Blood pressure builds up, pushes the brain laterally, might sink down, push on the brain stem, and then you're in a mess, and you can die very quickly in an hour or two after the symptom, the injury, no symptoms, and all of a sudden, boom, the person's dead. Contrast that to a subdural hematoma. Subdural hematoma shown on the bottom of the diagram there. This is beneath the dura mater, obviously. Subdural hematoma. So the blood is pooling between the meninges and the brain tissue. Okay? That is typically one of our bridging veins has been ruptured. This is a much more insidious onset. So remember these bridging veins take the blood from the deep within the brain out to the dural sinuses. These get less flexible with age, so typically this damage or this lesion is in the elderly. You can get these lesions in childbirth, where the brain is squashed around and moves during childbirth, but usually it's in the elderly, where these veins, these bridging veins, are less pliable, and what happens, the patient falls and they don't realize that this has happened, just like epidural hematoma really. But because this is venous blood, it's very low pressure. The symptoms develop over weeks, if not months. So often these go misdiagnosed. There have been incidents of these patients being admitted to psychiatric hospitals for behavioural disorders. So the patient will come in 3 months after the accident, 2 months after the accident, and they'll be complaining of dizziness perhaps, maybe mild headaches occasionally, maybe uncoordination, ataxia. So sort of mild, non-specific symptoms that, yeah, you could ignore maybe, no big deal, I can live with it. Then they might come and see you because of ataxia. You might be more confused. You might have difficulty sleeping. Various issues that you don't really put together as a brain injury. And what's happened, of course, this blood has been pooling gradually, very, very slowly, beneath the dura mater, and it's pressing on the brain, just like the epidural hematoma is. But this is beneath the dura mater. It's venous blood. Low pressure, buildable symptoms take a long time. So you might be interviewing, taking a history of the patient. So so this confusion, this ataxia, this uncoordination. Can you think of a precipitating injury? When did this happen? Well, it's been getting gradually worse for months. Did you fall? No. Have you injured your head? No. Then husband or the wife might say, oh yeah, don't you remember you fell your last, at your daughter's birthday, 2 months ago, and you bumped your head? Yeah, but that was nothing. I was fine. But that was the incident that caused this rupture in the blood, in the vessel, these veins, and that's the one that's gradually been causing the blood falling up. And you can see one subdural hematoma there. So obviously the thing you do, you can see here, that's the dura mater, cut open here, and suctioning that blood out of that big old hematoma. We've had some of these patients in the lab, and sometimes when you dissect the skull out and look at one of these hematomas, the brain there is just mush in that area. Just like oatmeal, it's all soft and it's just been atrophied completely. Okay, so that's a subdural hematoma. Make sure you know the difference between a subdural hematoma and an epidural or extradural hematoma. How they come on, what the signs and symptoms of these are. And they're not uncommon. Last slide. You should all take a look at this. It's a very nice review. This is out of your textbook. A very nice review of the clinical profile of some of cerebral vascular accidents. It lists the type of accident, the onset and cause, whether you see any blood pressure changes resulting in that injury, special findings, and you can look at the CT scans and MRIs. You won't probably see those. Well, maybe in PT you do diagnostic imaging, but the main thing is to look at the pathology, what actually happens in these infarcts, in the subdural, epidural, subarachnoid hemorrhage, etc., etc. There's a nice summary of basically what we've been talking about. You can determine to a certain extent what the injury is, what by the onset of symptoms, what type of symptoms they have, what precipitated those symptoms. So take a look at that table. It's a nice overview of the various types of cerebral vascular accidents patients might present with. Okay, enough of that. The autonomic nervous system. Okay, so far we've only been discussing the somatic nervous system, or the voluntary nervous system. So when we've been talking about a patient with ataxia, with weakness in this muscle, spasticity, whatever, obviously we've been referring to the symptoms present in the skeletal muscles. Those muscles, of course, are innervated by the somatic nervous system. They regulate coordinated muscle action, posture, etc., etc. The autonomic nervous system, no, innervates involuntary or smooth muscle. I think involuntary perhaps is not a good word for it, because you can voluntarily control these muscles if you've got feedback on them. I can control my stomach muscles. I can make my stomach churn more. I can increase my heartbeat. I can increase the temperature in my finger if you gave me feedback on it. So you can voluntarily control these, but you don't normally aware of that because you don't have feedback on those muscles. But the autonomic nervous system then controls our organs and smooth muscle. Okay? This is non-striated muscle, remember. So whereas this is responsible for regulating the internal environment, as it were, of the body. The internal environment, our blood temperature, our blood pressure, whatever, vasodilation, stomach churning, all those internal processes are regulated by the autonomic nervous system via smooth muscle and glands, various glands. The somatic nervous system regulates our interaction with the external environment, moving towards a chair to sit down, picking up a cup, water, whatever. Those functions of picking things up, interacting with the environment around us, the external environment, obviously is the somatic nervous system. Autonomic internal regulation. Okay? Within, that's it. That's all the autonomic nervous system. It's a little more confusing than a somatic nervous system. Maybe not. In a somatic nervous system, remember, there's a single neuron in a series that goes from the cord or the brainstem to muscles. So when I want to activate my biceps, or when I want to activate my cheek muscle, there is an alpha motor neuron sitting in the brainstem in terms of the cheek muscle, or sitting in the spinal cord in the ventral great horn, remember, goes out, goes to that muscle and contracts that muscle. Of course, there's tons of them in series and in parallel going to those muscles, to those motor units. In the autonomic nervous system, we have a chain of 2 neurons to get to the effector, whether it be a gland, an organ, any muscle. There's a series of 2. Okay, the 2 neuron linkage. Okay, and they're shown here. So this would be the brainstem or the spinal cord. We have a preganglionic and a postganglionic neuron. We've talked about this before. we have a ganglion somewhere where those two neurons synapse. That's called an autonomic ganglion. Those autonomic ganglion are outside the cord somewhere. Preganglionic neurons are usually B fibers, small but myelinated neurons. Small diameter, myelinated, fairly slow conducting. The postganglionic neurons, those ones after the ganglion that go actually innervate the glands, the muscles, whatever it is, are going to be C fibers, unmyelinated, slow. You don't have to have fast transmission down our autonomic neurons. Okay? And for every B fiber, we have roughly about 32 C fibers. So there's a big divergence at those ganglion. So at the autonomic ganglion, one B fiber or many B fibers will come in, but the ratio is round about 1 to 32. So there's a lot more C fibers take off from each individual B fiber to innervate that organ, that smooth muscle that we're talking about. Okay? Okay. Within the, so remember we got a parasympathetic and a sympathetic nervous system portion, right? We all know that. You've done that in your A&P show. Now these have opposite effects in essence, don't they? One's got the flight and fight system. You've heard that term, obviously. The sympathetic and the parasympathetic is going to be called what? Rest and digest. Okay? And it's basically they compete against each other in most places in the body. They compete to control smooth muscle, the pupil, whatever you're looking at. And it's like the water tap principle. You heard that when we talk about the effect of these systems on the body? It's like filling your bathtub with water. You put your hand in and you feel it's a certain temperature. And your hot tap and your cold tap are both running now. How do I make that bath water warmer? I have two options. A, I turn up the hot water, or I turn down the cold water. And that's exactly what you can do in the autonomic nervous system. You can elevate one and inhibit the other, or vice versa. And they'll change the temperature of the bath water, they'll change the muscle tone or the organ, whatever you're looking at, by either increasing one or decreasing the other. They'll have exactly the same effect. And certain drugs are targeted as parasympathetic agonists or sympathetic antagonists that will have the same effect as each other, those two drugs. And we'll look at the drugs at the end of this section. Those drugs are based on or formulated around what neurotransmitters these systems release. The parasympathetic nervous system, remember, releases acetylcholine at the ganglion and at the organ. So in other words, the parasympathetic preganglionic neurons will release acetylcholine. The postganglionic parasympathetic fibers release acetylcholine. So both the pre- and postganglionic neurons within the parasympathetic nervous system release acetylcholine. However, on a sympathetic nervous system, the preganglionic neuron releases acetylcholine, but the postganglionic neuron releases norepinephrine or noradrenaline, same thing. Okay? So every organ that is innervated, or every smooth muscle is innervated by postganglionic sympathetic neurons are going to be affected by norepinephrine, except one place, the sweat glands. Sweat glands in the skin, they respond, because of the receptors they express, they are going to respond to acetylcholine. Acetylcholine is released in those sweat glands. Okay? So sometimes the sympathetic nervous system is called the adrenergic system. The because it runs on noradrenaline, the adrenergic system. Okay? Whereas the parasympathetic system will be called what? Cholinergic system. The cholinergic system. Because it releases acetylcholine. See, the cholinergic system and the adrenergic system. Okay? Not shown on this diagram, but there is a third part of the autonomic nervous system, not shown here, called the enteric nervous system. This is usually thought of as a part of the autonomic nervous system. Some books you won't see it there. The enteric nervous system is like a miniature nervous system all to itself that is influenced by the autonomic nervous system. The enteric nervous system controls the gut. Okay, all the intestines, the motility, the function of the stomach and the gut, etc., is controlled by the enteric nervous system, and we'll look at that briefly at the very end. Okay, that's just showing the same thing there. Nothing new there. Okay. Another term for the sympathetic nervous system is called the thoracolumbar system. The thoracolumbar. Because the preganglionic neurons within the sympathetic nervous system start in the thorax, the thoracolumbar regions of the spinal cord. Okay, thoracic and lumbar regions. Basically T1 down to the end of the cord, which is around about L2. So from T1 to L2, we find our preganglionic neurons coming out of the spinal cord. Piggybacking usually, well, in various places, but down the neuron, down the spinal nerve to get to the arms and whatever. Okay, so the cell bodies of those sympathetic preganglionic neurons are going to be found between T1 and L2. So that's why it's called the thoracolumbar system. Now, competing with that is the parasympathetic nervous system. Trying to turn that off, trying to turn down this flight and fight system is the rest and digestive system. And those neurons, those parasympathetic preganglionic neurons, do not start in the spinal cord. Well, not for a majority anyway. They will come out of our 4 cranial nerves we've talked about so far. Okay, the vagus being the largest, and way down the bottom of the cord we have S2, S3, S4 sacral levels. Obviously it's not physically down there. Those are going to be a few parasympathetic preganglionic neurons come out of there. Okay, so for the lower organs in the abdominal colon, kidney, bladder, genitalia, those organs are going to be supplied by parasympathetic fibers coming out of S2, S3, and S4. But most of our organs in our chest and upper abdominal regions are going to be supplied by the vagal nerve, obviously. The vagal nerve is your big, major parasympathetic supply to the trunk. Okay? And we, of course, we have our oculomotor, glossopharyngeal, facial nerves up there with some parasympathetic fibers within them. Okay, so let's look at the sympathetic nervous system. What the function of the sympathetic nervous system then? Flight or fight. So it's going to mobilize energy. It's going to get us psyched up. So our catabolic processes are going to dominate. Catabolic, we're going to break down energy to release energy into our system. Whereas the parasympathetic anabolic processes are going to dominate. So sympathetic mobilizes energy. Heart rate, what happens to heart rate? Increase or decrease?
Increase.
Increase. So we want to get ready for a fight. What happens to our blood sugar? Increase blood sugar. Blood pressure. Increase or decrease? Increase. Q, stroke volume, cardiac output. What will happen there? Increase. More stroke volume. Respiration, breathing, up or down. Will I breathe faster or slower? Faster. The bronchioles, within the lungs, dilate or constrict? Dilate. We want to get more air in quickly. We're going to run a mile quickly, or something. We're going to get away from something. Coronary arteries, arteries around the heart. Dilate, constrict. Blood vessels going to the heart itself. Coronary arteries. Dilate or constrict? Dilate. We'll dilate. We want blood going to the heart muscle itself to pump. So we have dilation of our deep coronary arteries. We have dilation of big arteries going to muscles. Because we want to run quick as a lion attacking us. We want blood to get to the muscles. What about our peripheral blood vessels in the skin? Dilate, constrict. Constrict. We constrict our blood vessels in the skin to allow us to shunt more blood to important things like muscles and the heart. That's why your skin can often go cold and clammy in certain situations with sympathetic innervation. The liver will secrete glycogen. Peristalsis, up or down? Down. Peristalsis, churning the gut, decreases. That's you rest and digest. Okay? Pupils, dilate or constrict? Dilate. The pupils constrict. Your eyes go wide open and pupils get light in quick. Parasympathetic supply dominates, the pupil will constrict. Sympathetic, pupil will dilate. Okay? Your hair will stand on end. You'll get goosebumps. You try to make yourself look larger, like a cat. More scarier. You will secrete sweat. Make yourself slippery. So your enemy can't grab hold of you. Saliva. What happens to saliva? It decreases and gets thick. You get a different type of saliva secreted. You know when you're nervous, you're about to have an exam, or you're in trouble and you have to face the consequences, You go to see the principal or whatever it was, like I used to do all the time. And your mouth goes dry and you start to get that chewy saliva in your mouth, that thick saliva. That's your sympathetic nervous system kicking in. You've got these big globs of, dry saliva in your mouth, and you're kind of choking it down. That's a different type of saliva being produced because the sympathetic nervous system is kicking in. Tear production will decrease with the sympathetic nervous system. So basically, the parasympathetic nervous system is going to do the exact opposite of everything else, everything we just mentioned. The parasympathetic system is going to do the exact opposite. Okay? This slide will get thinner. All those other things we talked about, you're going to see the opposite action when the parasympathetic nervous system is dominating. Okay, let's look at the anatomy now of the sympathetic nervous system. We'll come back to the parasympathetic, but we touched on the parasympathetic when we looked at our cranial nerves. Okay, so the sympathetic nervous system again, thoracolumbar, is going to come out of the spinal cord between T1 and L2. There's going to be a ganglion somewhere. Okay, but there must be a preganglion and a postganglion neuron. We've got to have it. There must be a ganglion somewhere in this chain. And those ganglion for the sympathetic nervous system are usually close to the spinal cord itself or close to the aorta. Okay? The parasympathetic ganglion like the otic ganglion, for example, we mentioned, the submaxillary ganglion or submandibular ganglion, those ganglion within a parasympathetic nervous system are close to the organ. They're close to the effector site, like just behind the eye, for example, the ciliary ganglion. But the ganglion in the sympathetic system are either close to the cord, the spine itself, the backbone, or close to the abdominal aorta. So let's look at this. How sympathetic neurons, pre-ganglion and post-ganglion, get to their destination. It's kind of a convoluted path, and there's various ways we can do this. Okay, so this is a cross-section through the cord between T1 and L2 somewhere, whatever. So we're looking at our pre-ganglion neurons. Where do they start? They start at this black dot there, okay, which is in lamina 7. We saw Clark's nucleus in lamina 7, but it's sort of on the outside of lamina 7. You can see it here. That grey splodge there is where our cell bodies of our sympathetic neurons start, and that's known as the intermediolateral nucleus. Intermediolateral nucleus. Intermediolateral nucleus. This is the equivalent of the ventral grey horn for our somatic nervous system. So our somatic nerves, our alpha motor neurons, our gamma motor neurons, remember, they start in this ventral grey horn here. But the cell bodies of our motor neurons in a pre-ganglionic sympathetic nervous system start there in the intermediolateral nucleus of lamina 7. Okay? So they then come out through a ventral spinal route, through a ventral route, just as a normal spinal nerve would do. Okay? But then it goes into this trunk. This is known as the sympathetic trunk ganglion. The chain of ganglion all the way down the cord. Like that. Okay? This is the sympathetic chain ganglion. So sometimes sympathetic trunk, sympathetic chain, various terms of it. These ganglions, whole chain, and go all the way down cervical to sacral levels. Even though there's no sympathetic neurons coming out at the cervical level, we have cervical ganglion. Here, we have 3 cervical ganglion, inferior, middle and superior. But there are no cervical neurons coming out of the cervical cord here. But we still have a chain there, and right down sacral, even coccygeal levels, there's a chain of these ganglion. So you can see this is more of an anatomical correct cross-section here. This is the chain here. And those usually are called our paravertebral ganglion. By the side of the vertebrae, that's what it means. Paravertebral ganglion. You can see how it lies right up against the backbone, the cord, the vertebra there, vertebral body. So, there are many situations where orthopedic lesions in the spine can affect the autonomic nervous system, affect the sympathetic nervous system, because of the close proximity of these ganglion, the paravertebral ganglion, against the spine here. And in the orthopedics class, when you look at the spine, like T4 syndrome, whatever, you'll learn how you can manipulate the spine and you will affect the autonomic nervous system. The sympathetic nervous system can present with lesions within it because of orthopedic problems to the spine. Because they lie alongside each other, right on top of each other, as it were. Okay? In your dissection made in the 60s, you'll see these. Alright, let's go back to this diagram here. So, we've got this pre-ganglionic neuron coming out of the cord, coming through the spinal ventral nerve root, but then it gets into this chain. It goes into this chain through this white ramus. There's a in and out pathway to this chain. You can see it anatomically correct here. You can see the white ramus here, and then the grey ramus takes the fibres out. So remember, the ganglion are a little relay station. Pre-ganglion come in, post-ganglion go out, usually. Pre-ganglion neuron comes in through the white ramus. We get a synapse, as you can see here, let's say, and a post-ganglion neuron takes, the dotted line in this case, takes that information out the grey ramus, and then they'll piggyback on the spinal nerve to get to the effector. Okay? That's some neurons do that. So there's sort of three pathways through these paravertebral ganglions. Three types of chain or ways of getting through these paravertebral ganglion. The first one, neuron comes out, synapse of the ganglion, neuron goes out. Okay, so pre-ganglion neuron comes in, white ramus, synapses, grey ramus takes the post-ganglion out to the spinal nerve, and away we go. That's one way of getting through this ganglion. The second thing can happen. Neuron, pre-ganglion comes out, enters the chain via the white ramus, as usual, but does not synapse at that level. It does not synapse at a segmental level. However, it goes up or down instead. Because we have to get supply to those cervical ganglion and those sacral ganglion that do not have their own innervation. So in other words, I have no C5, C6, C7, whatever nerve roots coming out here. So in other words, nerve roots from T1 and T2, etc. come into the chain, go up the chain before synapsing on one of those cervical ganglion. The post-ganglion takes over then and goes out. Those, of course, are the neurons we have to get to the head, for example. There are no sympathetic neurons in our cranial nerves. So to get our sympathetic supply to the head, we have to go up into these cervical ganglion. We then get post-ganglions coming out, piggybacking on the carotid arteries to get into the head. That's how we get our sympathetic supply to the pupil, to the lacrimal glands, whatever. Those cranial nerves, the parasympathetic fibers, they supply those organs in the head. But to get our sympathetic supply into the head, we have to go up through the neck, up to the carotid artery. And we can have problems with that. We can get lesions in that chain taking stuff to the head. And we'll see things like Horner syndrome. We'll talk about that later. Okay, all follow me so far? So I didn't design this. Okay, so again, one way is the neurons come in, directly synapse segmental level and leave through the grey ramus, the spinal nerves. Second pathway, neurons come in, do not synapse at segmental level, but go up or down segmental levels before synapsing and coming out. You can see the third way here. You can see this brown line comes right through here, and it does not synapse at all. It does not synapse at all at any of those chain ganglion. It carries on straight through them without synapsing. Okay? Those neurons carry on to go to one of these what's known as collateral ganglions. And there's got to be a ganglion. There's got to be one. So those neurons that did not synapse in the paravertebral ganglion synapse later in what's known as a collateral ganglion. And those, there's three major ones of those. There's three major collateral ganglions shown here. And they lie alongside, find a picture, a good picture of that. Here. They lie alongside the abdominal aorta. Okay? And they have got names to them. Okay? We have them, let's show the names on this one. The most superior is known as celiac ganglion. Can you read that there? Hand that anyway. The celiac ganglion. The superior mesenteric ganglion and the inferior mesenteric ganglion. Have you heard these terms before in AP? Did you go into this much now? So you've got these three collateral ganglions: celiac, superior mesenteric and inferior mesenteric. Those ganglion lie right alongside the abdominal aorta. And that is the junction between the preganglion and postganglion neurons. Okay? Those neurons, after they get through the chain, they join to form nerves that go to these collateral ganglion. And those nerves are called the splanchnic nerves. See them here, greater and lesser splanchnic nerves. Okay? So the splanchnic nerves carrying those preganglionic neurons to the collateral ganglions. The prevertebral ganglion, another term for it, in front of the ganglion. Okay, did I say I think I said the wrong thing before. Did I? Okay, let's get this straight. The chain that lie alongside the cord these ganglion here are called paravertebral ganglion, or sympathetic chain ganglion, or sympathetic trunk ganglion, or trunk ganglion, whatever. They're paravertebral, they are alongside the vertebrae. The three collateral ganglions out here that lie alongside the abdominal aorta are sometimes called prevertebral ganglion. They're in front of the vertebrae. They're on the abdominal aorta. Always in terminology. Okay? So, the nerves that go through the chain to end on the collateral ganglion are known as splanchnic nerves. Those collateral ganglion then give rise to postganglionic neurons that go to all these organs. You can see them there. Okay? The lower organs, stomach down, basically. Stomach down are going to be supplied by these postganglionic neurons coming out of the collateral ganglion. That's how we get our sympathetic supply to those organs.
So the collaterals are the same as the pre...
Yes. Collateral ganglions are prevertebral ganglions. Is that the same thing?
And that's those three.
And those named things, celiac, superior and inferior mesenteric. That's kind of complicated, so walk out through this slowly. Sort of. Alright. There are some neurons that go through the paravertebral ganglion, carry on to those collateral ganglion and go straight through those. They do not synapse anywhere. These pre-ganglion neurons carry on straight all the way and end up, this is very, very small percent of these, and they end up on their adrenal medulla, the adrenal glands. Okay? So some neurons that supply the adrenal glands do not synapse on the way anywhere. The pre-ganglion neurons goes all the way to the adrenal glands. But I told you there must be a ganglion somewhere. There must be a pre and post ganglion neurons. So where are those post ganglion neurons?
Are they right in the gland?
The adrenal medulla itself is, the tissue is millions of post ganglion neurons. The adrenal medulla tissue itself is comprised of nerve cells, post-ganglionic sympathetic neurons. And what does the adrenal medulla secrete into the blood?
Adrenaline. Adrenaline?
Adrenaline. Noradrenaline and adrenaline, or epinephrine and norepinephrine. Epinephrine and norepinephrine are very similar in makeup. The adrenal medulla secretes 80% of what it secretes will be epinephrine. About 20% of what it secretes into the blood is norepinephrine. So its major job, the adrenal medulla, is to secrete epinephrine into the bloodstream. It's an endocrine gland, and that epinephrine circulates around the blood. 20% is norepinephrine. Of course, most of our norepinephrine comes from our nerves going to the organs. I mean, our sympathetic post-ganglion neurons secrete epinephrine around, norepinephrine to the organs, etc., etc. Epinephrine and norepinephrine basically are flight and fight neurotransmitters, aren't they? They're going to increase heart rate. They're going to, all those things we talked about, are going to be a result of release of epinephrine and norepinephrine. They're both vasoconstrictors. Well, what they'll do in terms of vasoconduction and vasodilation will depend on the receptor in which they act on. It depends what the organ expresses, what receptor they express. A beta-1 and beta-2 and alpha-1, alpha. Have you heard of beta-1 and beta-2 receptors, alpha-1, alpha-2 receptors in it? Yes? No? No? Alright, we'll get to that. We'll talk about drugs a little bit, but in the pharmacology classes. So beta-1 and beta-1 receptors, beta-1 and beta-2, on the heart, they place the heart, they allow heart rate increase. If you want to decrease heart rate, what kind of drug do you give them?
Blockers.
A beta blocker. When you talk about somebody's on beta blockers, they're on beta blockers because they've got what?
High blood pressure.
Hypertensive patients, you'll see a lot of them will be on beta blockers. Beta blockers are blocking beta receptors. They're preventing the sympathetic nervous system increasing heart rate. That's what stops your high blood pressure, beta blockers. You exercise in these patients, their response to exercise is going to be blunted, of course. Don't put a patient on a treadmill on a beta blocker and you go, oh, come on, work hard, your heart rate's only 90, I want you up to 140, or whatever, and you start cranking the treadmill up, this person's never going to get there, they're going to keel over before you do that, because they're on beta blockers. You should have noted that in their chart. Beta blockers are going to are going to blunt that heart rate response to exercise. Okay. So, let's go back to this diagram again. So, we've got neurons coming in to these trunk ganglion, synapsing directly, they're leaving, some going up and down the chain and then leaving, and some going straight through the chain and leaving. Okay? those ones that don't go straight through, but synapse here, go out to the grey ramus, and what happens to those then? Well, they will piggyback on our spinal nerves, on our ulnar nerve, on our thoracic nerves, whatever. Okay? They piggyback on our normal somatic nervous system nerves and go out to the arms, the legs, the trunk, the periphery. Because those are going to end up on our sweat glands and our smooth muscle in our blood vessels in our extremities. Remember, there is no parasympathetic supply to our arms, or legs, or chest wall. Our blood vessels, our sweat glands, our recti pili muscles in our skin that make our hair stand on end, they do not have a parasympathetic supply, unlike most of the organs. So the blood vessel tone, okay, in my radial artery is going to be influenced only by sympathetic nerves. Okay? So they either increase or decrease based on increased, decreased sympathetic tone, supply, innervation. There is no parasympathetic supply to our extremities or our skin and our trunk. Okay? And you can see how they get there. This kind of diet where like this one here. Okay? They basically piggyback onto the spinal nerves and go to the skin. In our arms, etc., our chest wall. The ones that get to the arms go through, find a good picture of this one, the cervical ganglion. Shown there. Oops, sorry, I've got to find a good one for this. There's a good picture somewhere. Yeah, that's kind of a picture there, look. So you can see the arm here, not very well shown, but whatever. The arm gets its sympathetic supply via the cervical ganglion. Specifically, the lower or inferior cervical ganglion. I'm sure there's a better picture than that somewhere. Okay, so let's get back to that again. So to get sympathetic neuron to my arms, they come out of T1, T2, T3 levels. They go up the chain to the lower or inferior cervical ganglion. Then they synapse with postganglions that come out, piggyback on the ulnar nerve, the musculaneous nerve, the radial nerve, go down and get to our blood vessels. Okay? The lower cervical ganglion has another name for it. The stellate ganglion. So remember, we have 3 cervical ganglion in a chain there. You can see them there. 1, 2, 3, but there's no arms on that diagram. But this lower one here is sometimes called the stellate ganglion. Where have you heard that term before? Have you heard, it means star shape. What's it called? Let me show you there. The stellate ganglion. Have you heard that term before? In your physical agents? A stellate ganglion block? No, I haven't heard that. I haven't done that. What's RSD? You've heard of that term? Reflex sympathetic dystrophy? Nobody's heard that term? Haven't come across that? Complex regional pain syndrome? That's the new term for it. But reflex sympathetic dystrophy, that is a nasty thing to have a patient have. The sympathetic nervous system is all screwed up. Reflex sympathetic dystrophy, that's the old term for it. Now they've got these complex regional pain syndrome terms. What that is, the sympathetic supply to the arm in this case is all messed up, and it's a nightmare to treat these patients. The arm is all red, it's painful, there's no known cause for this. They bumped their arm a little while ago, and now it's swollen up and they can't bend it. Has anybody seen somebody with that? It is nightmare to treat these patients. I have a patient with a knee, with RSD in the knee, all swollen up, blistering, sweating. There's no orthopedic lesion. You can't bend it, you can't put weight on it. Flares up, it's a nasty, nasty thing to deal with. Somebody would say something about the psychological element in it, maybe. So the severe cases when the arm, it's like Raynaud syndrome. You've heard of Raynaud syndrome, right? The same sort of thing. Problems with the sympathetic supply to the arm. Okay? That controls temperature, because that controls your blood vessel diameter. So in severe cases of this reflex sympathetic dystrophy, very nasty to treat. Very, very hard. They will go in and block that stellate ganglion. They'll put a pharmacological block. They'll kill that stellate ganglion to try to stop this massive outflow of sympathetic tone to the arms. You do not want to treat any good complex regional pain syndrome. It is very, very difficult. And the symptoms come and go without any kind of no weird reason.
Do they all have rashes and blisters and stuff?
Not all, but some, yes.
So how do you determine when they're faking it?
How when they're faking it?
Yeah, like someone that just like is a hypochondriac and just wants attention and stuff.
There's various tests you can do for that for malingerers, but nobody wants to fake this. Like, you know, if you're going to fake something, they'll fake low back pain, or bad neck, bad back. But you'll test to see if that's faking. You learn orthopedics. But this is a blotchy skin usually, and it swells up, and they can't bear weight on their foot or their knee, and you do very, 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 very gentle stuff with them. And it's nasty to treat, I tell you. The other part of these neurons, these neurons are coming up into the cervical chain. This is how we get our supply to our head. That's kind of shown here. To get our sympathetic supply to the brain, to the head, we have to go up the carotid artery. We have to go through the superior cervical ganglion. Okay? So that allows us to get our sympathetic supply into the head to counterbalance the parasympathetic supply from our cranial nerves. Okay? And we'll talk about that. Well, if this does get cut off, this sympathetic supply to the head, we can see things like Horner's syndrome. It's a classic sign and symptoms of a problem in a sympathetic supply to the head. Remember, our parasympathetic supply in the head is going to come from what cranial nerves? Oculomotor. What else? Facial. And what's the other one? Glossopharyngeal. The vagal comes out of the head. So we've got those three, the saliva, the tear glands, the mucus, the pupil, the lens. Those are all supplied parasympathetically by those cranial nerves. To counteract that, we have to get a sympathetic supply up there. And that goes up through the superior cervical ganglion, piggybacks on the carotid artery, and then splays out on those cranial nerves and arteries to get to those organs. Okay? If you lose that supply for some reason, for example, an aneurysm on the carotid artery, apical lung tumours. In other words, the apex of the lung is right under the neck there. You could have lung tumours in the apex of the lung that will cut off this sympathetic supply to the head. Carotid artery aneurysms, neck abscesses. There's various reasons why you sometimes can lose this supply to the head, and you'll end up with, look ahead here, Horner's syndrome. Horner's syndrome is a classic sign and symptoms of loss of sympathetic supply to the head. This was diagnosed, first named after his bloke Horner. Meiosis, what is that? Pupil constrict. Why would the pupil constrict? Because you've lost the sympathetic supply to what muscle? What muscle? Not the sphincter muscle. Remember, the pupil has two muscles, right? This is a sphincter muscle, innervated by the parasympathetic nervous system. Contraction of that causes what? Constriction. There's another muscle called the radial muscle, which is supplied by the sympathetic nervous system coming from the neck. Okay, if you contract that muscle, what happens to the pupil? It will dilate. So I have now killed the nerve going to the radial muscle. Therefore, what happens to the pupil? It constricts. You've got unopposed action of the sphincter muscle. Therefore, you get meiosis. Why would you get ptosis? The oculomotor nerve goes to the levator palpebrae. That's a skeletal muscle. You won't know this, but the reason why you get ptosis is because of Mueller's muscle. It's shown in this diagram here. Mueller's muscle is a little weird smooth muscle that lies underneath the eyelid. You have a smooth muscle underneath the eyelid called Mueller's muscle. Okay? Supplied by the sympathetic nervous system. You lose that muscle contraction, the eyelid will droop. So you could have ptosis from an oculomotor nerve lesion, the skeletal muscles within that. Okay? But you can also get ptosis from sympathetic issues, because the Mueller's muscle is a little muscle supplied by the sympathetic nervous system that lies underneath the eyelid that can cause ptosis. For example, this lady, I think it's a lady at the bottom and a bloke on the top. Look at their left, both their left eyes. Look at the eyelid and look at the relative size of the pupils. Constriction on the left, would you not agree, compared to the right? This is, if you get this chronically, they can actually do surgery. So they go in there and they'll cut out, they reset Mueller's muscle. And there they are doing it. Okay. You didn't want to see that? So here's the eyelid. You can see him injecting the anesthesia in it. And there's a little bit of muscle, it's that muscle flap there. And they've sliced that off. They slice that muscle and sew them back together again. They just get rid of that muscle. Stops it drooping the eyelid down. This is a quite common, but it's often done. To reset Mueller's muscle to to allow the eyelid to lift back up so it's not drooping down chronically. So that's Mueller's muscle. A weird little smooth muscle. No, not a straight muscle, it's not a skeletal muscle. Innervated by sympathetic nervous system. And ophthalmosis. What the heck is that? An ophthalmos. What is that? This is where, we haven't mentioned this yet either, there's an orbital muscle. In the back of the eyeball, not showing any diagram thing, no. There's a smooth muscle that lies behind the eyeball, that cradles the eyeball, like a sort of a pouch. Smooth muscle. If you lose tone in that muscle due to loss of sympathetic supply, the eyeball sinks into the back of the socket more. So the ophthalmos is a sunken eyeball. Its eyeball drops back into the face, as it were. And the easiest way to look at this, I saw one paper, if you have them tilt the head backwards like that, and you look up across their cheekbones like this, and you can see one eyeball sunken compared to the other. If you look up their cheekbones with their head lying on their back, and you can see one eyeball sunken down into the back of the head a little bit more. That's a definite sign. Orbital muscle damaged, sympathetic nerve supply damage to that, eye sinks back into its head. Last one, which Horner didn't actually include in his signs and symptoms, but it is there, anhidrosis. And that will be unilaterally typical. Horner syndrome is typically unilateral. It doesn't have to be. If you have neck abscesses on both sides, you can have both sides of the face affected. But usually, it's going to be a unilateral problem because you've got one-sided messed up. What's anhidrosis, do you think? Hydro, water, lack of sweat on one side of the face. Unilaterally. You have one side be dry and clammy compared to the other side that's normal, greasy, sweaty kind of texture of skin. The other side will be dry and clammy because the sweat glands have got no supply. That's Horner's syndrome. Classic sign of sympathetic interruption to the cranium, to the face. Make sense? Those are your 4 symptoms of Horner's syndrome, all due to loss of sympathetic supply to the head. Okay, a couple more things, then we'll take a break. Your brain's getting full up with this stuff, are you? Kind of come through it. Okay. Also arising, so we've looked at these, the superior and inferior middle cervical ganglion. The superior cervical ganglion supplies the head. The inferior cervical ganglion supplies the arms. Also rising out of those cervical ganglion are our cardiac nerves and our nerves going to our lungs. Those do not go through our splanchnic nerves to our collateral ganglion. You can see them here. So our cardiac nerves come out of T1 to T5 roughly, but they go up to the cervical ganglion. And then these nerves come out of the cervical ganglion down to the heart, down to the lungs. Okay? So this is how we get our supply to our SA node, AV node, all that kind of stuff. Sympathetic supply, which of course will do what to the heart? Increase it. What nerve decreases the heart?
Vagus.
The vagal nerve, the vagus nerve. That's parasympathetic. Often people think the only nerve they've heard of that goes to the heart is the vagal nerve. And so it must speed up the heart. People often will confuse vagal nerve with a sympathetic effect. They'll think the vagal nerve turns the heart on. The vagal nerve turns the heart off. Okay? The vagal nerve decreases bronchial diameter. The vagal nerve increases mucus production in the lungs. All bad in terms of you want to get oxygen to the lungs quickly. Okay? What I'll do now, I think, is we'll go through organ by organ where the sympathetic and parasympathetic supply comes from. That might kind of clear things up or might confuse things. Probably confuse things. Let's look at a couple of organs and then we'll take a break. This is a summary then. The eye. How do we get parasympathetic supply to the eye? Where do you know? Where's that from? Oculomotor nerve. Okay. What's the effect of the oculomotor nerve on the muscles of the eye? What's the effect? I'm talking about parasympathetic, not the skeletal muscles, moving the eyeball around. What muscles are in the eye that need to be supplied? Sphincter muscle, ciliary muscle. What does the parasympathetic supply do to those muscles? What's it going to do to the sphincter muscle? Constrict the eyeball, constrict the pupil. What's it going to do to the lens? Thickens it, fattens it, allows it to fatten. The natural elasticity. Therefore, what kind of focus will that have? Near point focus. Okay? Near focus. Where do those pre-ganglionic neurons in the oculomotor nerve start?
Oculomotor nucleus. Oh, the Ehringer-Westphal.
Ehringer-Westphal nucleus. That's the pre-ganglionic neurons. Where do the post-ganglionic neurons start? The ciliary ganglia. Mention you've come across this before, kind of sort of summarising it. Pre-ganglionic neurons, Ehringer-Westphal, that's a parasympathetic supply. Goes to the ciliary ganglion, which sits just right behind the eyeball. Post-ganglionic neurons take over, go to the pupil, go to the ciliary muscle. Okay? The sympathetic supply comes from T1 to T3. How does it get there? Pre-ganglionic neurons start at T1 and T3, T1, T2, T3, go into the white ramus and go upwards. Ascend into, so they get to the superior cerebral ganglion. Post-ganglion takes over, follows the carotid artery up into the head. Then it will piggyback on the ophthalmic artery, which comes off what other artery? Where does the ophthalmic artery come off? Internal carotid, very good. So it piggybacks on that, glues itself to that ophthalmic artery to get to the eyeball, to counteract the effect of the oculomotor nerve. So everywhere you've got to have a sympathetic and a parasympathetic chain. Let's do one more, then we'll stop. Saliva glands. What cranial nerves carry our parasympathetic fibers for the saliva glands? Facial and glossopharyngeal. The facial nerves, remember, they start at the superior salivatory nucleus. If you're in the facial nerve, if you're in the glossopharyngeal nerve, you start where? Inferior salivatory nucleus. Those are your pre-ganglionic neuron starting points. If you're in the facial nerve, you have to go through the ganglion known as submaxillary ganglion or sometimes called submandibular ganglion. Postganglionic neurons go to what glands? Facial nerve supplies what saliva glands? Sublingual and submandibular. If you're the glossopharyngeal nerve, inferior salivatory nucleus to start, they go through what ganglion?
Otic.
Otic ganglion. And end on what gland? The parotid gland. Produce saliva. Okay? Finally, sympathetic supply. Where in the cranial nerves is a sympathetic supply? Nowhere. So these ganglion, these sympathetic neurons have to come again through the superior cervical ganglion chain. Okay? Upper thoracic segments up to the superior cervical ganglion. Carotid artery, up they come, spread out on other little arteries going to those glands to counteract the parasympathetic supply of the cranial nerves. They're going to produce your nice, thick, chewy saliva. Your parasympathetic, nice, liquidy, fluidy, thin saliva. Okay, had enough? Yeah. Me too. Come on, guns, the organs, the heart, the lungs, that kind of stuff, next class.